This presentation will demonstrate the surgical technique for the repair of a fractured zygomatico-maxillary complex and an orbital floor defect using the matrix midface system. The matrix midface system has one screw diameter, the 1.5 millimeter screw, which can be used with all 4 plate thicknesses. There are self-drilling or self-tapping screws. Emergency screws are also available. One screwdriver fits all the screws. In this exercise, only bronze self-tapping screws will be used. The matrix midface system is used for all midface trauma indications. The plates are color-coded to indicate their thickness. In the practical exercise, the blue 0.5 millimeter thick and the pink 0.7 millimeter thick plates will be used. There is also a range of orbital floor mesh plates. For this exercise, a blue 0.3 millimeter thick plate is used. The objectives of this presentation are to show the correct anatomic reduction to reproduce the original position of the fractured and displaced zygomatico-maxillary complex, and the importance of restoring normal orbital volume. For zygomatico-maxillary complex and orbital floor fractures, preoperative CT scans in axial and coronal cuts are standard. Additional sagittal and 3-dimensional reconstructions are often helpful. Radiographs may also be used in certain circumstances. To begin, a 0.5 millimeter thick adaptation plate is used for the zygomatico-frontal suture. Then a 0.7 millimeter thick oblique L plate is applied at the zygomatico-maxillary buttress, followed by a 0.5 millimeter thick adaptation plate at the infraorbital rim. Finally, the orbital floor defect is repaired with a 0.3 millimeter thick orbital floor mesh plate. The matrix midface instruments needed are the 2.4 millimeter self-drilling threaded reduction tool with the T-handle and the screwdriver handle, the in-plane plate bender, 2 standard plate benders, the plate cutter, the mesh cutting scissors, the mini plate holder, the 1.1 millimeter drill bit with 6 millimeter stop, the screwdriver handle, and the screwdriver shaft with spring-holding sleeve. Zygomatico-maxillary complex fractures with an orbital floor defect can be approached through a combination of an intraoral upper buccal sulcus incision, an upper eyelid incision, a transconjunctival incision, or a lower eyelid incision. All relevant fractures are exposed before reduction and fixation. The zygoma has several articulations, and it's not always necessary to expose all of them to properly reduce and stabilize the fracture. However, the more complex the injury, the more exposures may be required. This is the fracture of the zygomatico-frontal suture. The fracture of the zygomatico-maxillary buttress, the fracture of the infraorbital rim, the fracture and defect of the orbital floor, and the fracture of the zygomatic arch, which is not normally repaired. In the clinical situation, the reduction of the zygomatico-maxillary complex fracture is begun by inserting the 2.4 millimeter self-drilling threaded reduction tool with a screwdriver handle through a stab incision in the skin into the dense bone of the malar eminence. The reduction tool must be positioned away from the areas that will be plated later. The tool should not be fully inserted. The screwdriver handle is disengaged from the reduction tool by pulling back on the sleeve. The T-handle is mounted by pushing the sleeve forward until it is fully engaged with the shaft. The sleeve is then released. The T-handle is used to manipulate the bone fragment until the fractures are reduced. The fixation begins with a zygomatico-frontal suture. A 0.5 millimeter thick, 20-hole long adaptation plate is selected. In this exercise, it's trimmed with the plate cutter to 5 holes. This 5-hole plate is contoured using the in-plane plate bender so that it passively adapts to the contours of the zygomatico-frontal suture. The plate is held in position with the plate holding forceps. The first hole is drilled through the inferior plate hole closest to the fracture using a 1.1 millimeter drill bit with 6 millimeter stop. This hole is chosen so that the plate can be used later to reduce the fracture gap. A 6 millimeter long screw is inserted using the screwdriver shaft with holding sleeve. The screw is not fully tightened so that the plate can still be manipulated. The plate is pulled superiorly to close the fracture gap. Then the second screw is placed just above the fracture line. Both screws are fully tightened. The plate hole over the fracture line is left free. The repair of the fracture of the zygomatico-maxillary buttress is next. A 0.7 millimeter thick 2 by 3 hole oblique L plate is selected. It is contoured with 2 standard plate benders to correspond to the anatomical features of the zygomatico-maxillary buttress. The plate is positioned on the thick bone of the buttress, taking care to avoid the tooth roots. The first hole is drilled in one of the inferior plate holes, just below the fracture, using a 1.1 millimeter drill bit with 6 millimeter stop. A 6 millimeter long screw is inserted. The screw is not fully tightened, so that the plate can still be manipulated. A screw is placed on the opposite side of the fracture line. Both screws are fully tightened. Next is the repair of the fracture at the infraorbital rim. A 0.5 millimeter thick 5-hole adaptation plate is selected. 1 screw is placed on each side of the fracture. The reduction of the zygomatico-maxillary complex is checked by inspecting the alignment of the fracture fragments in as many places as are exposed. When the reduction is satisfactory, the reduction tool is removed. Screws are inserted into the remaining plate holes of each plate, except for the plate holes that lie over a fracture, which are left empty. In most cases, the zygomatic arch does not need to be repaired. The last step of the procedure is the repair of the orbital floor. In a clinical situation, after the orbital floor is exposed, an orbital retractor can be used to elevate the orbital contents. A 0.3 millimeter thick orbital floor mesh plate is selected. The radial design fits the conical shape of the orbit. The mesh cutting scissors are used to trim the plate to the correct anatomical size. It is important to use a large enough plate to span the entire defect. There must be a sufficient number of screw holes available to fix the plate posterior to the inferior orbital rim. 1 or 2 screws are adequate. In order to protect the soft tissues, all sharp edges have to be trimmed. The plate is contoured to meet the anatomical features of the orbital floor and rim. Accurate contouring is crucial to restore the normal orbital volume. In the clinical setting, the soft tissues must be carefully retracted to avoid entrapment. Once the plate is positioned, a hole is drilled posterior to the infraorbital rim using a 1.1 millimeter drill bit with 6 millimeter stop. A 6 millimeter long screw is inserted. If necessary, additional screws are inserted until the plate is securely fixed in place. Post-operative imaging is used to confirm that the reduction and stabilization are correct. In severe cases, it may be necessary to have additional exposure and fixation across the fracture located in the zygomatic arch. Another option for orbital floor reconstruction is titanium contourable mesh plates.